Welcome back. I'm Dr. Pete Davis. In the first part of this lecture series we looked at the normal thyroid. It's now time to look at the pathological processes that commonly affect the thyroid gland, namely over and underactive thyroid problems. Let's go. So we're going to begin with thyrotoxicosis or hyperthyroidism. People often get confused between hypers and hypos, but this is hyperthyroidism. So these two individuals have the same problem, but they look rather different. And you can look into their physical features, and you can come up with a number of ways in which their clinical signs of thyrotoxicosis differ. More about this later. They actually represent the two main forms of overactive thyroid that we see. These are the common symptoms that people experience in descending order when they have thyrotoxicosis. I often say to patients, everything goes too fast. Everything's going too quickly. And the commonest ones you see are feeling an emotional change of nervousness, experiencing sweating, fatigue, palpitations, and weight loss. But actually the symptoms people experience are very individual, and some forms of thyroid disease can occur many times throughout somebody's lifetime. And one of the interesting things is people tend to experience the same symptoms if they have recurrent episodes of thyrotoxicosis. There's also quite a marked difference in the frequency of these symptoms depending on the patient's age. So that's your takeaway message for hyperthyroidism. Everything goes too fast. What about these age differences? Well, younger people tend to experience weight loss, heat intolerance, sweating, and shaking, whereas older patients, it can be other types of presentations, particularly those affecting the heart with angina or onset of atrial fibrillation. And sometimes older people, rather than feeling as if everything's going too fast, can feel completely worn out. They can feel tired all the time, and it gets this term apathetic thyrotoxicosis. So we've said there are two common forms. Let's look at them in a bit more detail. Graves' disease, named after an Irishman called Robert Graves, not a disease that puts you in the grave, and toxic nodular thyroid disease. We'll look at those in some more detail, but there are others that you might want to look at for extension question purposes. As you would imagine, the test results are going to show that the thyroid hormone levels are really high, and as a consequence of negative feedback, TSH is very low, so low in fact it cannot be measured. The laboratory typically reports this as less than 0.01. Some important tests that we consider in people with thyrotoxicosis help us decide which of these two common forms it might be, and these are thyroid autoantibodies. Common antibodies that we request are called TPO, or thyroid peroxidase antibodies, and a much more specific type of antibody, TRAB, can help us sometimes. So we often would request that if we think the person is likely to have Graves' disease. What are the differences between these two main types? Graves' disease, patients tend to have a smooth goiter. Toxic nodular goiter, well, it may be more pronounced on one side. There may be multiple nodules that you can see, so sometimes the form of the goiter in the neck is different. What about the eyes? Well, people who have any form of overactive thyroid have changes to their sympathetic nervous system. It's like the sympathetic nervous system is really G'd up. And this can lead to activation of the levator palpebrae superioris muscle, giving rise to lid lag and lid retraction, which we see very commonly. As well as that, there are some more specific changes in Graves' disease, which you'll see in the books called this word, exophthalmos, spelt in different ways. The name we give, the acronym we associate with the sort of eye disease that we see related to autoimmune thyroid disease is given this cuddly name, TED, Thyroid Eye Disease. It's a bit of a catch-all, but most people who use this are talking about the type of eye disease that we're seeing in Graves' disease. Some other things can happen in people with autoimmune disease, as well as this way in which it can affect the eye. It can affect the skin as well, and give changes at the front of the legs called thyroid-associated dermopathy. It also has a very confusing secondary name called pretibial myxedema. And of course, myxedema generally relates to an underactive thyroid, so it's unfortunate that name gets associated where the majority of these people actually may have thyrotoxicosis rather than an underactive thyroid. As we've implied, because this is an autoimmune condition, it's Graves' disease that's associated with positive antibodies. So in toxic nodular goiter, it's as if a switch has been flicked within the thyroid becomes autonomous, it's a field change which accounts for why it can occur in many sites, and you can get these multiple nodules. No link to autoimmunity, so you don't have any dermopathy, you don't have any of these specific eye changes, and unless just by chance you have positive antibodies, antibodies are not going to be found. Graves' disease is a classic autoimmune disease. It affects women much more commonly in men. It runs strongly in families. And as we'll look at in a minute, it does have this very classical relapse and remit type of natural history. It's associated with other autoimmune diseases. We call these organ-specific autoimmune diseases. It doesn't associate with the non-organ specific autoimmune diseases like rheumatoid arthritis, but it does with all of these mentioned on the slide and others too. When I meet somebody with Graves' disease, I'll often sketch out this type of a schematic on the back of a bit of paper to explain what's happening to them. I'll say to them, your thyroid has gone overactive. You meet a very nice doctor, typically your GP, who makes a diagnosis, gets you onto treatment and brings the thyroid under good control. After you've been on treatment for about 18 months, the problem goes away and we typically stop treatment at that point in the hope it won't come back. But we know it comes back in the majority of people. So we expect after a variable length of time, sometimes decades, that the problem will come back. But there's more to it than that, because people with Graves' disease can experience an underactive thyroid as well, and over time they can develop both an overactive and underactive problem. And that can help people understand the natural history of the problem they have and why we use anti-thyroid drugs in the way we do. And of course we're all in the business of helping patients understand their own condition so they can take control of it. If you're trying to explain to somebody why they need to take tablets for such a prolonged period as 18 months, it can help them to know that it's not going to be forever, and there is a reasonable chance that they're going to have decades without the need for treatment. So the antibodies that we measure, particularly these TSH receptor antibodies, are actually tied up in the pathogenesis. You can think of these TSH receptor antibodies as flavour of ice cream. They can do a variety of different things. The mix of the antibodies can change over time. So what they do to somebody's thyroid gland over time can change, and that accounts for the natural history. There can be, what I was taught in medical school, thyroid-stimulating immunoglobulins, thyroid-stimulating antibodies. And these, as we saw earlier on, because of how TSH works, can do one of two things or both. They can affect thyroid growth. So you have a patient with goiter, but who is not thyrotoxic. Or you can have antibodies that stimulate thyroid hormone synthesis. So they're this TH plus, they're thyrotoxic, but they don't have a goiter because these antibodies don't stimulate growth. or you could have antibodies that stimulate both. Let's call that strawberry flavour ice cream. On the other hand, you can have antibodies that bind to the TSH receptor at the thyroid and do neither of these things. And that can account for the hypothyroidism that we see in people who have Graves' disease. Very interestingly, some people can have years of an apparent underactive thyroid treated with thyroxine, and then all of a sudden the balance of these antibodies changes and they revert to an overactive thyroid. It can cause an incredible amount of confusion when that occurs. That's, I think, what makes thyroid disease fascinating. A few words about thyroid-associated eye disease or ophthalmopathy. We've got a few examples, quite gross examples of people with external ophthalmoplegia in this case. Pretty gross swelling around the eyes in this case, with you get an impression that the eye has been pushed forward, which is what we mean by exophthalmos. This person has this inflammation around their eye. One of the chief simple symptoms that people with thyroid eye disease get is that they make a very poor quality of tears. So the tears that the eye makes cause constant streaming and running of the eyes. So runny eyes can be a symptom of the dry eye that we see in TED, thyroid eye disease, and it's very simply treated with artificial teardrops. It's still a mystery about why thyroid eye disease occurs. There are certain things that are important to share with the patient about this. It's much more common in people who smoke, much more common. And we know that if people can give up cigarette smoking in early thyroid eye disease, that can have a major improvement on their thyroid eye disease progression. We also know that if people develop periods of hypothyroidism associated with high TSH, that this can make thyroid eye disease worse. And for this reason, we tend to avoid treatments for overactive thyroid that would perhaps more readily cause hypothyroidism. It occurs in approximately 2/3 of people who have Graves' disease. Tends to be more men than women who get it. There's a sort of a simple autoimmune sort of idea about this, that there are some sort of shared epitopes in the eye that mean that the autoimmune process starts to direct itself towards some elements in the eye in the same way as they attack the TSH receptor in the thyroid. So people experience dry eyes, as we discussed, and the treatment is simple eye drops. They also get very bad glare, which is managed by sunglasses, and the swelling we saw in those previous pictures sometimes requires steroids, but could be treated with loop diuretics quite well as well. Something to bear in mind is for some people who develop thyroid eye disease, you can't see anything on the outside. If you think of the sort of eyeball on MRI scans, and you've got sort of strap muscles around the eye, these strap muscles become thickened by added gubbins or glycosaminoglycans that gets laid down in these muscles, which in turn prevents the eye from moving, but can lead to pressure on the optic nerve. That's the most worrying form of thyroid eye disease that we see. When we look at the person in the clinic or at the bus stop, we don't see a problem with their eye, and they could be experiencing visual loss without us at all being aware. So any red flag eye symptoms needs an urgent referral to ophthalmology. We mentioned the thyroid-associated dermopathy that happens. This is what it looks like, and this dreadful term that gets associated with it. These features of thyroid eye disease and dermopathy, they are not linked to thyroid status, in that they don't happen more if somebody has an overactive thyroid. So that was Graves' disease. What about toxic nodular thyroid disease? Lovely example there with two juicy nodules in this person's thyroid. Well, it can run in families sometimes, but it's often sporadic. Tends to occur in areas of relative iodine deficiency, and in the past that used to be areas of Central Europe, areas of Pakistan, lots of places in the world which are a long way from the sea. In the UK, if anybody's from Derbyshire, woo, it used to be called the Derbyshire Neck in the UK. I sometimes call it the Great Bridge Neck in our area, I guess because I used to have a clinic in Tipton. So the concept is that an increased TSH drive is required if people have insufficient iodine to make thyroid hormone, and over time the bombardment of the TSH receptor leads to the formation of autonomous tissue, meaning the thyroid can function without the need for TSH. So what happens to the thyroid hormone levels? Well, because the tissue is working autonomously, there are small increments to thyroid hormone production from the thyroid. Now, we don't really see that clinically at first because the levels of thyroid hormone are still within the normal range, but they're higher than they should be, so they begin to lead to TSH suppression. So TSH levels get progressively lower, and very soon they become completely suppressed. So despite there being no TSH around, year on year free T4 continues to go up in small increments. So people experience a gradual onset thyrotoxicosis, and this can take decades to occur. So it often presents in older people. Because it occurs in areas of relative iodine deficiency, what we see is the thyroid preferentially makes T3 instead of T4 because there's not much iodine around. So the presentation can be with a fully suppressed TSH, with a level of free T4 which isn't amazingly high, but a level of free T3 which gives you the diagnosis. Now the laboratories don't often routinely give you a free T3, so if you suspect T3 thyrotoxicosis, you may need to specifically request a T3 test. We have three common treatments available for thyroid overactivity. Our mainstay is the use of anti-thyroid drugs. Radioactive iodine has a place, it's more popular in some places around the world, and surgery has its place as well, although it's not a popular treatment with patients, and as time goes by there are fewer surgeons out there who can perform thyroid surgery safely for our patients. We talked when we looked at the natural history of Graves' disease how we would use carbimazole over typically an 18-month period before somebody ends up in remission. There was a school of thought that longer courses with carbimazole could give higher remission rates. I'm not so convinced about the evidence, but because it's quite a safe treatment, some patients would opt for long-term carbimazole if they've had a number of relapses. I've had some patients in the last few years who are semi-professional athletes, and after experiencing a relapse, each of them decided they wished to stay on low-dose, long-term carbimazole, and it seems to have worked very well for them. Sometimes because of patient preference, sometimes because of multiple remissions, patients can choose radioactive iodine. Very much comes down to patient choice. For people with toxic nodular goiter, the natural history is this problem is not going to go away. It also occurs more in people who are somewhat older than those with Graves' disease, and it tends to be because of its permanency that more people would choose radioactive iodine. The way we're using it in the case of nodular goiter is something my parents may have said to me when I was a child: taking down a peg or two. So what you're doing with radioactive iodine is you are taking out the areas of thyroid autonomy, and if that works successfully, the areas of normal thyroid could begin working normally again. Because the nodular change is a field change within the thyroid, what we sometimes find is somebody could have successful radioactive iodine treatment, but then decades later other autonomous areas take up the cause and the problem happens again, sometimes 30, 40 years after somebody has had successful radioactive iodine treatment. Because of the shape and size of the thyroid gland, and if it threatens somebody's breathing or swallowing, surgery is probably a slightly more common option to take than it would be in people with Graves' disease. I meet a lot of elderly patients who feel very well on low-dose carbimazole and don't want to mess around with radioactive iodine or surgery, and in a low-dose carbimazole is a very safe and effective treatment. I said that around the world choices differ. If you're in Japan, antithyroid drugs are top of the tree, and radioactive iodine not so popular. If you're in America, this is the American Thyroid Association, radioactive iodine is somewhat more popular. It may have to do with how funding works for various treatments, and multiple follow-up appointments are very expensive, so in economies that are trying to reduce hospital appointments, radioactive iodine could be a more popular option, you can see, from an economic perspective. A few words about carbimazole. It works at multiple levels in the formation and release of thyroid hormones. So it blocks iodine uptake and organification. It also blocks the release of preformed thyroid hormone. It works as a single dose each day, even though the plasma half-life is actually quite low, and it does so because it gets actively concentrated within the thyrocyte. After you've begun on carbimazole, it takes a few months, typically 3 to 4, to bring the thyroid under good control. We begin on a high dose, and then we progressively bring it down to a low dose of carbimazole as the thyroid comes under good control. We worry a lot about a rare side effect that can occur with these drugs called agranulocytosis. Agranulocytosis occurs in a dose-related way, and it's very unlikely to occur if people are on 20 milligrams or less of carbimazole, which influences our choice of dose. Like every drug, carbimazole can have these common side effects like rashes and upset to the GI tract. And if people can't use carbimazole for whatever reason, we can use this alternative called propylthiouracil. One special case in which we use that is in women who plan to become pregnant and in early pregnancy, as there is emerging evidence that there may be a signal towards teratogenesis, towards abnormalities caused in babies in women taking carbimazole. These are not common effects, but they are sufficient to direct us towards an alternative. We talked earlier about how many of the symptoms of thyroid overactivity are to do with the sympathetic nervous system being sort of G'd up by the excess thyroid hormone, and for that reason beta blockers can be a very effective symptomatic relief treatment for somebody who's got these pretty irritating thyroid overactivity symptoms, and can help people sleep. The beta blocker of choice that we use most, propranolol LA, single dose once a day. So if you're on a single daily dose of carbimazole and a single daily dose of propranolol, it makes for a treatment plan that most people find they can comply with very nicely. Radioactive iodine works by causing direct follicular cell destruction. It comes usually in the form of a capsule or as a liquid, and it's given to the patient as an outpatient. We know it's pretty safe, but being a treatment that's based upon radioactivity, we do worry about excess cases of cancer, and registry studies tell us that this This hasn't been seen as a signal that would worry us clinically in long-term follow-up of thousands of patients who've used radioactive iodine to treat benign thyroid disease. A problem with radioactive iodine is that after you've had it, you have to wait a very long time to work out whether it's helped you or not. 4 months, up to 6 months perhaps. And when it does work, it can work too well, and it can lead to hypothyroidism. When it doesn't work, you require multiple doses, and about a third of people will require 2 or more doses. Because of concerns about radioactive iodine in unborn children, we're very careful not to give it to women who could be pregnant, and we'll often do a pregnancy test on the day of radioactive iodine testing and counsel women to avoid pregnancy for a number of months after treatment. We talked earlier on about how, because it can cause hypothyroidism, it could exacerbate thyroid eye disease. If our hand is forced to use radioactive iodine under those circumstances, there is a school of thought that you could use corticosteroids to reduce the chances of thyroid eye disease happening. So you need a good surgeon to undergo thyroid surgery, who's done a lot of this work recently. We're very fortunate in our area to have an excellent thyroid surgeon. It's considered more under those circumstances. Patient preference perhaps should be there as well. It's very effective, but can lead to hypothyroidism. People who get keloid scars need to take particular care. After you've had your neck operated on once, you probably don't want to have a surgeon going back into your neck area because of how it messes up all the fascial planes in the neck. Those are the common side effects of surgery, as you'd see with any kind of surgery, I guess. Recurrent laryngeal nerve damage is fortunately very low, said to be about 0.5%, but each individual surgeon will have their own figures on that. If you took away the parathyroid glands as well, you could induce hypocalcemia and hypoparathyroidism. So surgeons are really careful to preserve parathyroid gland function. Temporary thyroid gland overactivity can occur, which we call thyroiditis. And the most common form of this is as a manifestation of a post-viral problem. It's a little bit analogous to what we talked about with autoimmunity in the eyes, about how something has happened, some sort of shared epitope has happened, and we believe that in a sort of immune way, after a virus infection, something has happened, some sort of epitope has been recognized in the thyroid gland that leads to the thyroid coming under a destructive attack by the body's immune system. So this is different to TSH receptor antibodies in Graves' disease. In this process, the thyroid gland is actually being destroyed in a temporary way. Sometimes it can be silent, but most commonly it causes pain in the front of the neck, typically a couple of weeks after a virus infection. And the thyroid can actually feel very hot in the neck as well with the pain. There can be a overactive phase, and what's going on there is the release of pre-formed thyroid hormone. So it's not that the thyroid is over-functioning, it's just spilling out all the thyroid hormone it has stored in the colloid all in one go. After that's all spent and all the thyroid hormone has been thrown out into the circulation, there can follow an underactive phase as well. So just draw in that people get an overactive thyroid, it lasts a few months, then it goes back to normal. Alternatively, they get the overactive thyroid and then it goes underactive for a few months before going back to normal. Important to note that this is a self-limiting condition. It lasts a few months and then you're back to normal. It's very rare to have a permanent thyroid dysfunction following this. Because it's self-limiting, it often requires no treatment. Through this overactive phase, some people can benefit from beta blockers. Why don't antithyroid drugs work? Maybe we'll put that in as an extension question. They don't work. And then when you go through this underactive phase, if it lasts a few months, some people may require a little bit of thyroxine to take them through that phase. With a plan, you're going to have them off all treatment at the time, maybe 6 months or so later, when the problem's blown over and gone. A special instance of thyroiditis occurs following the delivery of a child, postpartum thyroiditis, and this occurs for up to 1 year following delivery. It's relatively common, and again different to sporadic thyroiditis. This is a manifestation of autoimmune disease that links to autoimmune thyroid disease. In this case, it's usually silent. There is no pain in the neck, and it can be frequently followed by permanent hypothyroidism. And like all the other autoimmune diseases we talked about, strongly associated with other organ-specific autoimmune diseases, and especially type 1 diabetes. So how would you know if it's temporary thyroid gland disturbance or not? The history is king here. Pain in the front of the neck following a virus infection with no family history of thyroid disease. You've got one set of thyroid tests, you repeat them, and you've actually seen a big change. It shows that whatever thyroid problem you have, it's settling very, very quickly. You check the thyroid antibodies and they're not there. If you are confused, you could do a radioactive iodine uptake scan. Actually, we use technetium-99 rather than radioactive iodine these days. And because the thyrocytes are being attacked and they're throwing out preformed thyroid hormone, you see no uptake. The thyroid isn't working anymore. It's not taking up a surrogate for iodine as it should. And that's pretty classic, a no uptake scan. We talked about the treatments just earlier on. So this is an unusual but special form of thyrotoxicosis that bears this name, should be a capital B, Jod-Bazdov, I think they call it in Germany and Poland, and it's iodine-induced thyrotoxicosis. It occurs where people have autonomous thyroid tissue, and as physicians we throw them a whole load of iodine. I'll give you a case example. I met a man, I think he was about 70 years old, and he had critical aortic stenosis. And he was having coronary angiography prior to surgery for this problem. They wanted to know, did he need some bypass surgery done of his coronaries at the same time they replaced his valve. So they did his coronary angiogram, and to get that coronary angiogram, you need to use contrast medium that happens to contain an awful lot of iodine. Now, on the coronary care unit, he became incredibly unwell, developed severe supraventricular tachycardia, and this poor man actually died before he could have surgery. And the answer was, by giving him all this iodine, it meant that his thyroid gland, with its autonomous tissue, was throwing out a huge surge in thyroid hormone levels, and he experienced what gets called thyroid storm as a result of this. But his thyroid storm was caused by iodine-induced thyrotoxicosis. So that's a very dramatic case example of how awful this, devastating this can be sometimes. But actually, in most people that receive large doses of iodine in this way, it's a self-limiting condition. The thyroid eventually resettles when the iodine load has gone away. Let's flip things and talk about an underactive thyroid. A lovely before and after example there, and a few other examples shown on the slide. An example of a young person with cretinism, congenital hypothyroidism showed there as well. So let's flip things and talk about hypothyroidism. Incredibly common. About 3.5% of people on primary care registers are on thyroxine for hypothyroidism. So when you're dealing in your Firm 1 teams, this is a really common long-term condition to see. Commonest form we see gets called Hashimoto's thyroiditis, usually associated with a smooth goiter. When we talked earlier on about Graves' disease, we said that could cause an underactive thyroid as well. Because you've got these TSH binding inhibiting immunoglobulins that we talked about earlier on, it stops the thyroid growing, so you get an atrophic thyroiditis. So some underactive thyroid, you have a goiter, and some you don't. Isn't thyroid disease interesting? Other rarer forms are after surgery, radioactive iodine, thyroiditis we've covered well. Some drugs can lead to hypothyroidism, and you can always get secondary hypothyroidism because your body isn't making TSH because of pituitary disease. Okay, we talked about everything going too fast in hyperthyroidism and in hypothyroidism. Everything goes too slow. The treatment's very straightforward, using thyroxine. This is the typical daily dose that people require, and you could get too much thyroxine, in which case you start to feel rather like somebody with thyrotoxicosis. Because it's a lifelong, long-term condition, you can sometimes forget to take your tablets, so medication non-concordance is a very common cause of a high TSH, but normal free T4, and variable levels of TSH over time. So if you looked at a time graph of somebody's thyroid function tests, they'll very commonly show a pattern that you can relate to the patient as requiring some sort of reminder system to allow them to take their drugs normally. Drugs can interfere with thyroxine. We talked about plasma protein binding, so drugs that affect plasma protein binding can lead to changes in the available thyroxine in the circulation. And this is a very old-fashioned drug for cholesterol lowering, which can bind thyroxine in the gut and prevent it being absorbed. In older people, because going from a position of an underactive thyroid to euthyroidism fast could lead to the onset of atrial fibrillation or angina, we go low, 25 micrograms, and we would build that dose very slowly over time. What we're aiming for is somebody who feels well and who has a normal TSH, normal thyroid functions. But we know perhaps about 2% of people who have hypothyroidism doesn't really feel that great afterwards. So what we try and avoid is making a promise that everything is going to feel normal again after somebody's been treated for hypothyroidism, because sometimes it won't. So how people feel on these on thyroid hormone replacement is really, really important, but there is an element here of managing people's expectations as well. So thanks so much for your attention. There was a lot to cover in that lecture, and we'll be right back with installment 3.